TB treatment regimen under RNTCP. Goals of TB treatment are: decrease the case fatality and morbidity by ensuring relapse-free cure, minimize and prevent development of drug resistance, and render the patient non-infectious, break the chain of transmission, and decrease pool of infection. Efficacy of regimen means successful early outcomes like high sputum conversion, high treatment success, long-term outcomes like low relapse, low emergence of drug resistance. There are two phases in first-line TB treatment: intensive phase and continuation phase. Click on each tab to know more. Intensive phase. 4 drug combination, out of which 2 bactericidal drugs are required in the initial phase. Kills most bacilli. The intensive phase is not extended beyond 2 months, even if the sputum smear is positive at the end of IP. Continuation phase, that is CP. Eliminates most residual bacilli and reduces failures and relapses. Numbers of bacilli are low, and there is less chance of selecting drug-resistant mutants, so 3 drugs are used. Let us now look at the classification of anti-TB treatment. It can be classified as first-line and second-line treatment. Click on each tab to learn more. We will learn about each type in detail. The topics covered will be as follows: first-line drugs, patient flow, and first-line regimen dosage. The topics covered in second-line treatment are as follows: second-line drugs, second-line regimen and dosage. In second-line regimen, we will cover all oral H-mono and poly-DRTB regimen, DRTB treatment algorithm, shorter MDR-TB regimen, and all oral longer MDR-TB regimen. It is established that in the treatment of tuberculosis, it is of importance to achieve peak serum levels of all the drugs simultaneously, so that maximum bactericidal effect is obtained. This is achieved by administration of all the drugs at the same time. This also renders operational convenience of advising the patients to consume all the drugs at the same time. Hello, we are first-line drugs for anti-TB treatment. Click on each one of us to know more. Isoniazid, call me H. I'm a potent drug exerting early bactericidal activity, preventing the emergence of drug-resistant mutants to any companion drug, and have low rates of adverse drug reactions. Rifampicin, you may call me R. I'm a potent bactericidal and sterilizing drug acting on semi-dormant bacilli, which multiply intermittently, causing relapse. Pyrazinamide, IMP, a bactericidal and sterilizing drug effective in eliminating the semi-dormant bacilli multiplying slowly in an acidic environment. Ethambutol, call me E. I'm an effective bacteriostatic drug helpful in preventing emergence of resistance to other companion drugs. Streptomycin, and I am S, a bactericidal drug I'm known to reduce septicemia and toxicity. We will now see the dosage schedule of first-line drugs for an adult patient. Click on the individual drug to see the dosage. Dosage for isoniazid is 5 mg per kilogram daily, ranging from 4 to 6 mg per kilogram. Dosage for rifampicin is 10 mg per kilogram daily, ranging from 7 to 15 mg per kilogram. Dosage for pyrazinamide is 25 mg per kilogram daily, ranging from 20 to 30 mg per kilogram. Dosage for ethambutol is 15 mg per kilogram daily, ranging from 12 to 18 mg per kilogram. Dosage for streptomycin is 15 mg per kilogram daily, ranging from 15 to 20 mg per kilogram. We will now see the dosage schedule of first-line drugs for a child. Click on the individual drug to see the dosage. Dosage for isoniazid is 10 mg per kilogram daily, ranging from 7 to 15 mg per kilogram. Dosage for rifampicin is 15 mg per kilogram daily, ranging from 10 to 20 mg per kilogram. Dosage for pyrazinamide is 35 mg per kilogram daily, ranging from 30 to 40 mg per kilogram. Dosage for ethambutol is 20 mg per kilogram daily, ranging from 15 to 25 mg per kilogram. Dosage for streptomycin is 20 mg per kilogram daily, ranging from 50 to 20 mg per kilogram. Roll over to the individual drug to see the adult weight band-wise dosage for each drug. Frequency of dosage of first-line regimen is as follows. Single daily dosage, 4 weeks per month, that is 28 doses. No extension of intensive phase. The continuation phase may be extended by 12 to 24 weeks in certain forms of TB like central nervous system TB, skeletal TB, and disseminated TB, etc. First-line regimen. Let us see the treatment regimen for first-line drugs as per the type of TB case. New and previously treated cases. Age sensitive, R sensitive, and unknown. Click on the tabs to know more about the regimen in intensive and continuation phase. Treatment regimen in intensive phase. Patient must be given 4-drug combination of isoniazid, rifampicin, pyrazinamide, ethambutol for 2 months. Treatment regimen in continuation phase. Patient must be given a combination of isoniazid, rifampicin, ethambutol for 4 months in continuation phase. Streptomycin is administered only in certain situations, example ADR with first-line drugs. Ethambutol is given separately for children to monitor ophthalmic ADR. Let us learn how to calculate the doses to be given in RNTCP daily regimen for new and previously treated cases, which include H and R sensitive or unknown cases. Click on the tabs to know more about the regimen in intensive and continuation phase. Intensive phase. There are 56 doses, that is 7 days a week for 8 weeks to be taken in intensive phase of regimen. Continuation phase. There are 112 doses, that is 7 days a week for 16 weeks to be taken in the continuation phase. Daily dose schedule for adults as per weight bands are given here. Please hover to individual weight band to see the details and number of tablets to be taken daily for the fixed dose combinations or FDCs. Daily dose schedule for adults as per weight bands are given here. Please hover to individual weight band to see the details and number of tablets to be taken daily for the fixed dose combinations or FDCs. Daily dose schedule for pediatric as per weight bands are given here. Please hover to individual weight band to see the details on number of tablets to be taken daily of dispersible FDCs. Daily dose schedule for pediatric as per weight bands are given here. Please hover to individual weight band to see the details on number of tablets to be taken daily of dispersible FDCs. Let us understand the patient flow in cases of drug-sensitive TB. A presumptive TB patient with symptoms will report to either a pharmacy or other stakeholders who may refer him to a laboratory or a treating physician at the PHI or any other facility. The physician will identify presumptive TB in the outpatient department and refer the patient for appropriate tests to NICSHE or Annexure 15A as follows. To a designated microscopy center for sputum examination. CBNAT laboratory for extrapulmonary pediatric and PLHIV cases, or other tests if patient is not found positive in above tests. Alternatively, the patient may visit the laboratory directly as well. The processes which are undertaken at this facility level are as follows. Appropriate specimen is collected and the laboratory technician performs the required tests. The patient is then registered on NICSHE if not already done. The test results of the patient are entered in NICSHE, and these results are then finally conveyed to the referral facility or treating physician and patient. After receiving the test results and reports, the patient reports back to the treating physician who now records a history of all previous treatment, initiates appropriate treatment, opens a treatment card for the patient, organizes dot and replenishes medicine, monitors dot treatment. The treating physician may then refer the patient to a female health worker or FHW, community health worker like ASHA or Anganwadi worker, who then do the following. Conduct a home visit, update the original treatment card at PHI, and retrieval of patient. Alternatively, the patient may be directed to the DOT center or a treatment supporter who then does the following. Provides the DOT to patient on a daily basis, records the treatment, and sends the patient for follow-up examination. After the treatment initiation, the patient is now in regular contact with the medical officer of PHI who does the following. Collects the treatment card, records the treatment outcome, updates the treatment card and submits the same tuberculosis unit after completion, and updates the information in NICSHE. We will now understand the role of nodal or district drug-resistant TB center committee in second-line treatment. Click on the committee to know their role in second-line treatment. The committee decides on a case-to-case basis the treatment for DRTB patients using second-line drugs. The need for admission of DRTB patients for initiation of treatment. Initiate the patient on standard regimen, shorter or longer, at nodal or district DRTB center on indo or outpatient basis. The committee decides on a case-to-case basis the treatment for DRTB patients using second-line drugs. The need for admission of DRTB patients for initiation of treatment. Initiate the patient on standard regimen, shorter or longer, at nodal or district DRTB center on inpatient or outpatient basis. The anti-TB drugs recommended for treatment of MDR and RRTB patients are grouped based on efficacy, experience of use in drug class, and aligned with revised classification as per WHO Consolidated Guidelines for Treatment of Drug-Resistant TB 2019. Grouping of second-line drugs. Group A are levofloxacin or moxifloxacin, bedaquiline, linezolid. It is recommended to include all three drugs in the regimen. Group B drugs are clofazimine and cycloserine or terazidone. One or both medicines can be included in regimen. The Group C drugs are to be added to complete the regimen when drugs from Group A and B cannot be used. Group C drugs are ethambutol, delaminide, pyrazinamide, imipenem cilastatin or meropenem, amikacin or streptomycin, ethionamide or prothionamide, para-amino salicylic acid. Let us now understand the second-line drug dosages. Hover to individual drug to see the adult weight band-wise dosage of them. Principles of designing a WHO recommended all oral longer MDR-TB regimen. In MDR or RR-TB patients on longer regimens, all three Group A agents, levofloxacin or moxifloxacin, bedaquiline, linezolid, and one Group B agent like clofazimine or cycloserine should be included to ensure that treatment starts with at least 4 anti-TB agents likely to be effective, and that at least 3 agents are included for the rest of the treatment after BDQ is stopped. If only 1 or 2 Group A agents are used, both Group B agents are to be included. If the regimen cannot be composed with agents from Group A and B alone, Group C agents are added to complete it. All oral H mono or poly-DRTB regimen is of 6 months with 4 drugs: levofloxacin, rifampicin, ethambutol, and pyrazinamide, with no separate intensive or continuation phase. As per diagnostic algorithm, second-line LPA must be done. If second-line LPA shows fluoroquinolones class resistance, replace levofloxacin with high-dose moxifloxacin. Do liquid culture and DST for detection of resistance to high-dose moxifloxacin and pyrazinamide. If high-dose moxifloxacin or pyrazinamide resistance, replace linezolid. If linezolid cannot be given, replace with clofazimine. If both linezolid and clofazimine cannot be given, add cycloserine. If both high-dose moxifloxacin or pyrazinamide can't be used, add 2 drugs of the 3: linezolid, clofazimine, cycloserine in the order of preference. Treat for 9 months in any of the 3 above situations. If there is R resistance, switch to the appropriate regimen. Shorter MDR-TB regimen is of 9 to 11 months. It consists of 4 to 6 months of combination of high-dose moxifloxacin, kanamycin or amikacin, ethionamide, clofazimine, pyrazinamide, high-dose isoniazid ethambutol, and 5 months combination of high-dose moxifloxacin, clofazimine, pyrazinamide, and ethambutol. If the intensive phase is prolonged, the injectable agent is only given 3 times a week in the extended intensive phase. If there is need to stop or replace any drug, stop the regimen and evaluate the patient to switch to all oral longer regimen. All oral longer MDR-TB regimen is of 18 to 20 months with no separate intensive or continuation phase. The regimen consists of levofloxacin, linezolid, clofazimine, and cycloserine, which are given for 18 to 20 months. Newer drugs like bedaquiline and delaminid are given for 6 months duration, while the dose of LZD is tapered to 300 milligrams after the initial 6 to 8 months of treatment. This regimen will also be used for treatment of XDR-TB patients with 20 months duration. All oral longer MDR-TB regimen situations are as follows. If bedaquiline is excluded in the first 6 months, then use delaminid. If delaminid cannot be used, use pyrazinamide plus amikacin or ethionamide. If both delaminid and pyrazinamide cannot be used, use amikacin plus ethionamide.
Needs to be stopped
if levofloxacin needs to be stopped in the first 6 months, replace it with high-dose moxifloxacin if SLLPA pattern suggests. Do LCDST for detection of resistance to high-dose moxifloxacin. If no FQ can be used, then use delaminid. If delaminid cannot be used, use pyrazinamide plus amikacin or ethionamide. If pyrazinamide cannot be used, use amikacin plus ethionamide. If 2 or more drugs are stopped in the initial 6 to 8 months, then use ethionamide plus pyrazinamide plus delaminid. If delaminid cannot be used, use ethionamide plus pyrazinamide plus amikacin. If delaminid and pyrazinamide cannot be used, use ethionamide plus ethambutol plus amikacin. If delaminid and pyrazinamide and amikacin cannot be used, use ethionamide plus E plus PAS. If 3 drugs cannot be used out of E, pyrazinamide, amikacin, ethionamide, or PAS, use imipenem cilastatin plus amoxiclav. The patient will need admission to the nodal DRTB center. If a regimen with a minimum number of effective drugs can still not be constituted initially, use drugs in this order: EPAS, imipenem cilastatin plus amoxiclav. If at least 3 drugs from groups A or B are not available in the last 12 months of treatment, then use 2 drugs out of ethambutol, pyrazinamide, ethionamide or PAS. As per the algorithm, the patients with rifampicin resistance and not detected with TB will be initiated on first-line treatment regimen while awaiting the results of first-line LPA and continued on first-line treatment if resistance is not detected to isoniazid. These patients will be monitored closely, and in patients with signs of non-response to treatment during follow-up, and another NAT test will be offered. If isoniazid is found to be resistant, the patient will be initiated on all oral H monopoly DRTB regimen at the PHI level while awaiting the results of SLLPA, and the regimen would be appropriately modified if FQ class resistance is detected on SLLPA at the N or DDR-TBC. The patients with RRTB will be considered for shorter MDR-TB regimen at N or DDR-TBC after ruling out the exclusion criteria for shorter MDR-TB regimen. The patients excluded from shorter MDR-TB regimen would be initiated on all oral longer MDR-TB regimen at N or DDR-TBC. In case of additional resistance on LCDST, the all oral longer MDR-TB regimen would be appropriately modified. The process of choosing the appropriate regimen for MDR and RRTB patients is as follows. In the presence of any non-DST based exclusion criteria for shorter MDR-TB regimens, like pregnancy, any extrapulmonary disease in people living with HIV, and disseminated meningeal or central nervous system TB, the patient will be initiated on all oral longer MDR-TB regimen. The patient will be initiated on shorter MDR-TB regimen if fluoroquinolone and second-line injectables class resistance is not detected. Second-line LPA results are not available. If there is no history of use or intolerance to any drug in the shorter MDR-TB regimen for more than a month, the rest of the patients will be initiated on the all-oral longer MDR-TB regimen.